Let's dive in a little bit deeper. We're going to shift our next presenter over to community health workers who are out there and sharing their experiences and what they've been doing, how they got into this line, and what they've been doing and what they're seeing. We're fortunate enough to have a panel that's been put together to share their experiences from Multnomah County Community Health Centers here today, part of the Multnomah County Health Department. We have a trio of featured community health workers here today: Juliet Munoz, Jeff Holland, and Leslie Esinga. And I would normally do a little bit of a long-winded introduction of each of those people, telling you a little bit about their background, but they're going to share that themselves here today. And trust me when I tell you, I think that they're going to do a much better job than I would. They've got a lot of background that's exciting to learn about. So those are going to be our main panelists here today. Supporting them are the program supervisors for the Community Health Worker Program, Ruby Ibarra and Sylvia Ness, who help shepherd this program and ensure that it is successful. So I think we should go ahead and get those mics rolling and get right to our fantastic panelists here today and learn more about their stories. Community health workers in the making. Panelists, Leslie, Juliet, Jeff, please, let's take it away.
Okay, awesome. Hello, everyone. My name is Jeff Holland. I'm a community health worker with Multnomah County Health Department in primary care. This work has been growing for quite some time now, and I'm very proud to have some of my colleagues on board here. Over on my right is Ruby Ibarra, and behind me is Juliet Munoz, and then to my left is Sylvia Ness. Sylvia and Ruby are the management team for the Community Health Worker Program in primary care. Historically, the health department utilized community health workers usually in specialty programs like Healthy Birth Initiative or Nurse Family Partnership, and not so much in primary care, with one exception, and that was Ruby Ibarra, who for many years was the one and only community health worker in primary care over at La Clínica de Buena Salud. And so I was working in a teen pregnancy reduction and STI reduction program, and because we did such a good job, the funding went away. And so I was faced with, do I want to be laid off, or do I want to take this newly created position in primary care at the Rockwood Clinic? And I'm fond of saying that I did not find this job found me, because it was an absolute perfect match for my skill set. I know that I grew up in a modality of privilege. I understand that, and that many of the people that I work with do not have this same convenience. I try and use that when I need to smooth out barriers for people who are experiencing any kind of barrier to getting their primary or secondary care. So that's how I happen to come to this work. As things progressed, and as the team learned how to utilize me, and I learned how the team worked in the primary care setting, we began to really sync and utilize each other's skills appropriately. We developed a referral process so that the providers could send us a message indicating what they wanted to have happen for the patient. But I learned pretty quickly that a lot of times what the doctors wanted for the patient were not necessarily the primary goals that the patient had in mind. So I learned pretty quickly to interview the folks that were referred to me and find out what their priorities are or were, and start from there. And once you start from there, you can get traction with other portions of the program. Say if they need an imaging appointment and they can't quite navigate making the appointment, I can help with that. If they need medical transportation, I can help with that. But again, I learned early on to find out what their priorities are and start from there. And now that this has been going on, let's see, I went to Rockwood in October of 2010. This is almost September of 2021. Our program has grown by leaps and bounds, and there are now community health workers in every primary care clinic, as well as school-based. And whereas before we seemed to be a luxury, now the primary care they act as though they can't live without us, if we're going to be off site. And a lot of our work takes place not in the clinic, but in the community. they get nervous if we're not right there available. So that's been kind of a turnabout and kind of funny. But it's been very, very satisfying to see the program progress and to see all the good we've been able to accomplish and how this role is beginning to be understood. And in Multnomah County, we're working on billing for our services, just like a provider bills for services. Now community health workers are building on that program so that we can actually get reimbursed based on the important work that we do. So that's kind of it in a nutshell. I would love to turn it over to my colleague Juliet and let her tell her version of things. Okay, thanks.
Hi, Juliet. Thanks for joining us for this today.
Hi,
Wanted to
Paul.
start by asking you the same question that we've been trying to run by everybody here today. Tell us, how did you come into being and doing this work?
So I started with the county in 2008 as a referral coordinator. And as a referral coordinator, I would find barriers for clients that kept them from attending their medical specialty appointments. And I found myself doing a lot of extra work trying to help them get to those appointments. My limitation was that I was tied to a desk. The opportunity for me to apply for a community health specialist role popped up in the computer, and I decided to take that step and apply. And I have found that it's the best thing I have ever done, not only for myself, but more for the community. I'm now able to take it to that next level that I wanted to be able to when I was limited. So I now have been a community health specialist for going on 3 years and enjoy every bit of it. Just getting clients to take in responsibility in their own health and teaching them the way.
That's fantastic. That's fantastic. Let's go ahead and bring Leslie in next and say hello to her and have her tell us a little bit about her relationship to this work. Hi, Leslie. It's really great to see you.
Hi.
We're kind of wanting to start things today by getting everyone's story. Would you mind sharing how you came to be doing this work?
Yeah. So I think it started when I was probably about 13 years old. And I didn't know that it had a name. I am from old school. I'm a 60s baby. I'm from a very small town. And the village raised me. And members of that village were doing this kind of work. And I was always in awe because those were our connectors. Those were our point of references. Those are the people that we always went to. When you come from a small town, there are people that know the business, right? And they're the ones that point you over here, you go over here. If you have an issue or a problem, they were the navigators, they were the connectors, they were the people who always made things happen. And so those were my mentors and those were my examples as I started to engage in our community center at home. I'm from the Midwest. Burlington Northern Santa Fe runs our hometown. So, you know, I'm a railroad chick. So when I got here to Portland, I had a lot of work. My previous work history was in housing, working with Home Forward, working on a major public works project in North Portland called New Columbia. And I was doing community development at that particular point in time. And I had this sexy little title of a community builder, right? And as I came in on the front end when we were actually moving out the entire community and worked to keep the community connected during that 2 years while the build out happened. And then was on the ground putting in those underpinnings of recreating community with a population that was significantly more than what was in place before everyone moved out. So we went from 300 units to 850 units with a home ownership component in play. So after I left there, well, one of the major things that I did there was I was a really strong advocate for one of our nonprofit organizations that were one of our community partners called Village Gardens. And Village Gardens, they did gardening and they worked a lot with immigrant refugee populations. And I said, we need a community garden in place to create connectedness within the community. And after I left Home Forward at New Columbia, after working 7 years with New Columbia, and then doing direct resident services at 6 other properties for 5 years, I went to work for Village Gardens. And one of the things that kept coming over to me, coming up in my mind over and over and over again, was how sick people were. Truly, truly sick. And I said, I'm on the wrong end of this flow. I need to go upstream. I'm seeing all the health disparities. I'm seeing all the social determinants of health as I work with these populations, but I want to move upstream. And so when I saw that all the work that I had been doing for all those years actually had a name, and it was called community health worker, community health specialist, that's when I applied at Multnomah County, and I got the job. And so I've been in that role for the past 5 years. And I now am one of those people that my mentors were in my small little hometown of 30,000 people, connecting people to resources, being the one that has answers, showing them the way, talking to them and encouraging them and letting them know that there are possibilities. Really, really working with them shoulder to shoulder, hip to hip, ankle to ankle, toe to toe, head to head, to show them that things can get better. So I'm truly blessed to be in this role, because this is a position that I prayed for. My prayers were answered, and I moved into this role, and I've been doing it ever since. I am at the Northeast Health Clinic, where there's probably half of the population there. A little less than half is African American. The other larger percentage of patients are from countries where Spanish is their primary language. And so the work that we're able to do with those communities where this word called social determinants of health and your zip code and lack of access to resources, monetary resources, and then all of the inequities and disparities that are part of health, those are the folks that I get to work with. And so it's truly a blessing.
Fantastic. Talk about making a difference for a large number of people. And this, from starting point of age 13, it's just like life's work stuff.
Yeah, it is, exactly. Yeah,
really, truly.
It was just a natural segue. So wow. Yeah, I didn't know you could get paid to do it though.
And you're doing something that you love and that you find incredibly rewarding. I think that's everybody's dream, right? To be able to be finding something like that. That's just so wonderful. Thank you so much for sharing so much of what brought this all into being. This is fantastic.
You're welcome.
Jeff, why don't we go back to you and let's have you continue telling us more of your story, please.
Okay. Oh, good. I remember that picture of me and Leslie. That's great. Well, I alluded to some of this during the intro segment. I was the second ever only community health worker in the primary care system. So they really, when I was signed to Rockwood, or when I took the Rockwood position, they really did, from management on down, did not really understand what it was I was supposed to be doing. So I had the job of educating the provider teams and so forth about my role and how I could be utilized to help their patients have better health outcomes by addressing situations outside the clinic that affect their health, social determinants of health. And so in a sort of a fortunate way, the only seat they had for me to take when I got to Rockwood was at a previous nurse's workstation. She had just retired, but that put me right in the middle of the provider team. And so I learned quickly how the medical assistants interacted with the patients, how the nurses interacted with the patients, how the providers interacted, and then how they interacted with each other, and the dynamics of how patients flow through a primary care clinic. So that was really, really useful. Like Juliet, I had also been a referral clerk way back in the day. So I found myself, like Juliet said, not just sending a referral to an outside provider for some outside medical service, but following through to be sure it happened and helping eliminate barriers to that sort of thing going on. So as the years rolled on by and we got good working with this team method, so I would either get a referral from a provider after they had seen a patient, asking me to reach out to this patient and address whatever needs they saw, or sometimes they would call me to come into a room. We call this a warm handoff, and interact with the patient right then and there if it seemed like the appropriate action to do. So that's what we did. And again, I don't know about all the timing and so forth, but after I came to the program in 2010, to primary care in 2010, by 2015, I want to say, we probably had community health workers in every clinic, all of them performing the exact same role and learning how to interact with the team and help eliminate those barriers that patients were experiencing to getting their health care. So, and again, we're now becoming more valued. Our role is becoming increasingly appreciated. And as I mentioned in the intro too, we're taking steps now to start getting Medicaid billing for the work that the community health specialists do. So that's kind of it on that segment. Okay, thanks, Paul.
So how do we determine how we engage with patients? So our workflow is referral based. You heard Jeff allude to that when he was talking. So those referrals can come from a lot of different sources. They can come from the PCPs, they can come from behavioral health, they can come from our acupuncturists, they can come from outside of the clinical setting, out of the primary care home. There are times when there are referrals outside of the clinic to different institutions, and they will circle back to us for additional assistance with certain things. We also just get cold calls from patients that we maybe have never engaged with via referral from inside the clinic that have asks of us because they may need help with navigation, or they're stumped with a particular issue or problem that may be health related or not. We also get referrals from our TCA team, which is the team that specifically addresses specialty referrals to organizations outside of the clinic. And there are times when we do our own referrals, in that we may be engaged with a family or an individual for one particular referral, but as we start to do our needs assessment, we find out that there are a lot of things embedded that are affecting the patient's health or affecting the well-being of the individual or the family. So sometimes we make referrals to ourselves, and then we know it helps us to keep track of our sanity, but it also lets us know that these are some of the issues that this particular individual or family unit is experiencing. So one of the other entities that's also in the clinic that we get referrals from is our clinical pharmacist. We have an in-house pharmacist that's different than the actual physical pharmacy that dispenses medications, where she works particularly with patients around understanding pharmacology, understanding their dosing, changing dosing with consultation with providers. And so she also sends referrals to us as well. The RNs, the LPNs, the medical assistants, even our operations supervisor. I mean, we get referrals from everyone who basically touches and interfaces with a patient, and we address them as they come. So I think I've wrapped up the referral process, which is what drives our work. And now I'm going to hand things off to my colleague, Jeff, who's going to talk about getting healthy produce to clients, because what we have come to know is that food is health. So he's going to talk a bit about that.
Thanks, Leslie. One thing that I am particularly proud of that we've accomplished during the growth of the community health work in primary care is access to better food. And I was noticing early on at the clinic I was working at, we were seeing a lot of people for diabetes. It was a big push on diabetic management and education. And part of that, of course, is eating fresh produce, fresh foods. And I began to look around, and I had this hint from a class I had taken way back in the day called medical geography. And I began to look at the resources for fresh produce around the clinic I was working at. And they were just all about the same, and they were all in major supermarkets. There weren't many little markets. So I began to look for farmers markets and things like this, and would refer people to those places to find produce. And the other angle is that fresh produce is expensive. So if you're on a limited budget, you can get a lot more miles for your food dollar out of junk food, and therefore all the health implications that go with that. So put my mind to it, and I don't know how I happened to come up with this particular connection, but I got connected with a gentleman, Jerry Hunter, who was working in corrections. And he was working with troubled youth, and part of his program was he was farming a plot of county-owned land, doing organic farming, and some of these troubled youth would join him as part of their retribution, let's say. And then he was taking this produce and providing it to corrections facilities for them to use for people who were spending time there. So as we friendlied up a bit, and I really got interested, and I went out and volunteered on the farm a few times. It was fun. I'm a gardener anyway. I asked him if he had enough that he could maybe once a month bring fresh produce to the clinic, and I could just give it to people, you know, as they came to and from their appointments as needed. And so we worked that out. And then I expanded that idea to set up a tent. We had whatever produce Jerry could bring. I put out a hot plate and some plates and napkins and utensils, and I would cook the vegetables and then hand out free samples to people as they came to and left their appointments, giving me an opportunity to provide some education, some produce if they wanted it. Then I expanded that to print up recipes and talk with folks about the best way to prepare certain vegetables that they were not necessarily familiar with. And then I think it was Care Oregon who came up with the idea of doing a mobile pantry. And for some months, they sent a truck with fresh produce out to our parking lot. And again, it was free, which is a great price, especially if your grocery budget is tight. From that idea, I think it was the Patient Self-Management Collaborative, a little interior group of folks began talking about this and realized that, you know, people of affluence can have these vegetables delivered to their door every week. You know, they pay a fee and all this yummy local fresh stuff shows up. How could we expand that model to the population that we serve? And thanks to Sylvia and the other players on the team, Ruby, they developed some relationships with the Knight Cancer Institute and with some local organic farms. And we came up with our community-supported agriculture program, wherein we recruit clients. I used to start recruiting them from the diabetic management panel, who we feel like could benefit from participating and receiving weekly fresh fruit and vegetables, and then having it subsidized so that it was affordable. And that got launched, and some of my colleagues really did a lot more of the groundwork on that, and they're still running the community-supported agriculture program in our clinics today. And I think I would like to let Juliet expand on some of that, because she's really been boots on the ground with the CSA program. So I'll give it over to Juliet. Thanks.
Thank you, Jeff. So yes, I joined the team in 2018. In 2019, I was asked to do recruitment for the Rockwood Clinic for the CSA program. CSA is about a 22-week produce program, which started as an on-site pickup. In 2019, we partnered up with 2 other clinics in the Rockwood community, one being Wallace and the other being Kaiser in Rockwood. I started with 20 shares, and that just was a setup at Kaiser Permanente there in Rockwood, where our farmer would come and set up a table, and our clients would come and shop for their produce. The produce varied every week. It was what the farmer harvested that particular week for their CSA. Clients would come in, pick their produce, talk to us. We'd get a little bit, we'd give them newsletters that our farmer would type up weekly, introducing the vegetables that were part of the share, as well as providing some recipes to give our clients ideas of how to prepare the shares that they were receiving. Once a month, we would have a cook from Sanger's that would come and do a cooking demonstration using the vegetables that were in that week's share. Our clients would get to try some nummy recipes and also ask questions of the farmers and the cooks to get ideas of how to prepare meals at home. We were able to offer these shares at a very low cost, using grants from organizations. The clients would pay about $20 a month, which equaled out to $5 a week for that produce. We were able to give scholarship for the ones that could not afford the $5. We were able to bill clients EBT cards for the produce that they were receiving. In addition to about $20 to $25 of produce, they were also receiving a pound of grains, oats, rice, beans, something from the Bob's Red Mill. That was a great benefit for the clients. I myself would go over to clients' houses and kind of give them ideas on how to prepare some of those grains that they were receiving with their share. This, of course, was all pre-COVID. Then in 2020, as we all know, COVID happened and there was the shutdown. So our partners, Sylvia, Zanger Farms, OHSU is another one of our partners, all put their heads together and came up with a delivery plan for our program. That year, we were able to serve 70 clients, all delivery based. Clients really appreciated having these fresh produce delivered to their home on a weekly basis. 2020 was also the first year that we were able to access flex funds from Care Oregon. Care Oregon has a program, Flex Fund, that offer payment for things that aren't covered through the insurance. And with collaboration between Zanger Farms and Care Oregon, we were able to come up with what's called a prescription vegetable program. Part of their health plan for better outcomes in health was access to fresh vegetables. So determining their health conditions and completing these forms allowed us to get funding for a good amount of our clients. And the additional clients that did not have the option to flex funds were given grants or paid that minimal fee. Moving forward to 2021, we received grants and additional flex funds were procured for some clients. We were able to serve 300 clients this year in the Multnomah County Health Department. This has been spread throughout 7 of our clinics and some of our partners. We are doing a strictly delivery program again this year. In addition to that, I believe that this year we were able to ask for about 160 shares were covered through the health-related flex funds through Care Oregon, which totaled to be a little bit over $100,000, which is great news because the grants that we have are now going to be able to carry the program for an additional few years and hopefully able to serve additional members in the community next year. We have participating in some evaluations so that we can provide data to our insurance companies, to our organizations that we ask grants for, so that we can show what clients, for example, BMI was prior to engaging in the program, and showing that outcome of what the outcome is after they receive those 22 weeks of vegetables. The greater news of the program is that this year we're going to be expanding our shares to the winter. In addition to the 22 weeks that they will be receiving, they're going to be getting 3 months of winter shares. That does cut down to every other week of deliveries due to the production cycle of fruits or vegetables. They don't grow as sparsely as they do in this summer and fall, but we will be offering vegetables to our clients every other week on the delivery basis as well. So that's how we've seen this program grow throughout the years. I know that originally it started with one clinic, and this year we've been able to offer it to all of our Multnomah County clinics. I think that's all I have for today on the CSA shares. And Leslie is going to speak a little bit more on this.
So prior to the implementation of the Community Partnerships for Health grant, of which Juliet mentioned, help with the execution of the CSA program at the various clinics. Northeast Health Clinic was not a part of that partnership yet. So we knew that there was definitely a need for access to healthy foods at low cost. Our clinic is not in a food desert. There is a local store called Safeway, but it's pretty spendy. That's probably within 2 miles away from the clinic. What we did, well, it first started off with one of our medical assistants who actually lived in the community that I used to work in, and we had developed a relationship. She actually lived in New Columbia, and she was one of our growers in our community garden there. And she created an opportunity for excess produce that didn't sell at their farmers market. She would bring it into the clinic, and we would merchandise it in the lobby, and it would be gone literally within 45 minutes to an hour. That's just how much of a demand there was. From there, it morphed into a partnership that we had with another program that operates within Multnomah County called the REACH program, which stands for Racial and Ethnic Approaches to Community Health. One of their primary objectives is to address chronic disease burdens within the African American community. As I mentioned before, a little less than half of our client base at Northeast Health Clinic is African American or from the African diaspora. So I was able to partner with them, and they set up a tent. They had 2 growers that were both African American farmers. We outreach to patients within the clinic to find out if in fact this was something that they had a willingness to do, because their responsibility was to actually come weekly to pick up their CSA. And once we pitched that tent in the parking lot, it's like people came out of the woodwork, and the demand was so high, and they only had the ability to grow for 50 individuals that particular year. The demand was so high that we had to turn people away. And we put them on wait lists for the next reiteration of the program. But if folks did not show up to pick up their CSA on a particular day, I would wheel whatever produce was left over up to our clinic and again display it. And literally within 5 minutes, the entire table would be empty because folks were just clamoring for it. It was the quality of the vegetables. It was the brightness of the vegetables. It was the taste that was so different than what they were getting at our local stores, Fred Meyer and Safeway, that made people really want to get the vegetables. And fruits as well. And we also had, they had a connection with the same organization that Juliet mentioned, Bob Bread's Mill, where they had various types of grains, sometimes a lot ancient grains even. And those were grains that were more familiar to our African families. They also had a partnership with Grand Central Bakery, where we had rounds and rounds and rounds of fresh baked bread that we also gave away. So it was a really robust program that a lot of people participated in. But now, for the first year, we are part of the CSA for Partnerships for Health. This is our first year, and we have 20 individuals that are enrolled in that. This is our first time out of the blocks. So we're waiting to see, what the feedback looks like, and to hopefully expand that next year. One of the other things is we believe in sharing the wealth. So we also have another clinic that's not far from us. There's not a Multnomah County clinic called the North by Northeast Health Clinic, and we were trying to pull them in as another community partner because they have some of the same client base that we have in terms of ethnicity. They specifically target African Americans within that catchment of that immediate neighborhood. But COVID and vaccine clinics and all that coordination, they're a small shop. It just did not allow them to engage this year, but we'll return back next year and also see if they want to be a part of this wonderful partnership that creates access to fresh fruits, vegetables, predominantly grains, as well as bread. So with that being said, we're going to segue into what does the relationship between CHWs and team members look like? And that would be me that would be leading up that conversation. So there's no chair shifting that has to happen. So what does it look like, or what has it looked like since CHWs were integrated into this medical model? You heard Jeff, my colleague, speak about what it looked like back in the day and how it's kind of morphed into what we currently see right now. Even though we were dispatched at all of the Multnomah County clinics, really understanding what it is that CHWs do, how do we do the work, because we're kind of like smoke. They call us in, we put out the fire. We take away the anxiety, we take away the stress, we find the resource. We're the listening ear, we're the connector, we're the mentor, we're the wind many times underneath people's wings when they're in crisis. And we're helping them to resolve all of those life issues that sometimes get in the way when you have less access to resources. So because of that, that allows us to develop a very special relationship with our client base. We have the luxury of spending more time with our patients than what providers do, than what nurses and LPNs and MAs do. And that we get the backstory. We get the understanding of what is going on with a patient or within their household that may be contributing to what that provider sees when they show up in the office. They don't know that, someone's son is, let's say, gang involved. They don't know that children are really struggling in school. They don't know necessarily that, a significant other, lost their job, or that, they're on the precipice of eviction. They don't know what led to that. So because we have that information that we can share with the providers and share with the entire care team, it creates a different kind of understanding and takes that out of the person who's in front of you to the story that's in front of you. And it also creates a different kind of sensitivity and empathy, I think, as care teams engage with families, when we're able to bring that knowledge, that knowing to them, And because sometimes, patients show up and they try to put on their best face in front of the provider, or they like to tell sometimes the providers what they think they want to hear. And so we're able to really, in many instances, be very real and candid with patients, and also to, like I mentioned before, provide the information that providers need to know, or may want to know, because we share as needed, because we don't want to damage that relationship in any shape, form, or fashion with, with the patient. And I'm very transparent. That's the one thing that we can be. We can be very transparent with patients and say, I think this is something that I think your provider may want to know about. Are you okay with me sharing that information with them? And many times they say yes. Very seldom do I hear a no. This is just between you and me because I'm just venting. And they need that listening ear as well. They need that shoulder to cry on. I can't tell you how many tears and how many tissues I've passed out over the course of this almost 6 years that I've been doing the work, because people are really going through things. And those things influence and affect health. And so being able to give that backstory to providers is monumental. We have I have certain people that I work with pretty consistently. We work with the entire care team, but there are certain people that I make it a point to really debrief with, because of what patients are telling me are their kind of discomfort spots as they engage with individuals within our clinic. One of those is around pharmacology, medication. And we have a clinical pharmacist, an in-house clinical pharmacist, I mentioned that before, who has that same ability to spend an hour with a patient. And a lot of times what drives that engagement or that referral to that clinical pharmacist is because patients say, I'm just taking too much medication. I'm taking fistfuls of medication, or I got this medication prescribed to me when I was in the emergency room. I don't know if I'm still supposed to be taking it. And I just don't take it because, I don't like the side effects. They don't know that that medication is not a medication that you have to be on forever and a day. Maybe it was just meant to be prescribed for a short period of time. And then they're supposed to discontinue. But because people don't understand pharmacology, and they've never really had someone to sit down and explain it to them. There are patients that are taking medications and they're on so many that they don't even know what they're on and why they're on them. So they can streamline, the clinical pharmacists can streamline the med list. The clinical pharmacist can make adjustments in medication after consulting with the provider. I mean, there are so many things, and it creates another touch point for patients within the clinic so that they feel more comfortable and are more willing to engage in every single facet of their care. Another person that I engage with quite often is our behavioral health specialist, because mental health we have a pretty significant population of individuals that are dealing with mental health issues and are concerned as well. And so sometimes, she will come and knock on my door. This is pre-COVID. And we would just hang heads and just talk about if she has seen that I've had any kind of interaction with a particular patient, and I'll give her the backstory. Because sometimes, when they're referred for one particular thing, when in fact, there are so many things that are feeding into the manifestation of whatever they're experiencing in terms of their mental health. So sometimes her knowing that is incredibly helpful as she engages, and it even informs the types of conversations that she has with the patient. So it doesn't just stop there with just clinical pharmacy and behavioral health. It really even happens with, providers, with all members of the care team, honestly and truly. I used to be one of the last ones that would leave the clinic because of the hours that I worked. And a lot of times the nurses would still be just on the other side of the door. And I would be able to, the RNs, and I would be able to just, take a moment and just, chat them up about particular patients. And, resoundingly, they would say, well, I didn't know that was what was going on. Or there'd be times when I would debrief with the provider about a particular patient, and they would say, Leslie, how did you learn so much? This patient has been my patient for, 5 years, 15 years. I never knew these things about them. How did you get them to open up? I said, I just leaned in and I listened. That's what I did. I just leaned in and I listened. And you'd be surprised by how many people just need a listening ear, because they're so overwhelmed with so many things that are going on in their lives. And to have somebody who's not there to pass judgment, someone there who's just there to offer, um, and be objective. I'm not a psychologist or a psychiatrist. I'm not. I have minimal training in that area, but I do know how to listen, and I know how to listen, actively listen with empathy. And I sometimes know the things to say, that people need to hear to create change, um, in regards to their health. So it's a wonderful opportunity for me to do that. And it's a wonderful opportunity that patients are able to cross my path, and I have that ability to turn whatever needs to be turned for a change to occur. And with that being said, I'm going to pass it over to my colleague Jeff, who's going to talk about some of his stories and how he also engages with team members.
Thank you, Leslie. You know, when Leslie mentioned getting the backstory on some of our clients and some of these patients, it reminded me of a case just now that I remembered. So I had a referral for a young lady in her third trimester of pregnancy, and she had stopped coming to the appointments at the clinic. And I heard language around this like non-compliant and failed the appointment, all negative. So I tried her phone, no answer, not available. So I drove to her last known address, the address we had on record for her. She answered the door. I explained who I was and that we had become concerned because she was, late in her pregnancy and we didn't want her to miss, necessary care. She explained they couldn't afford the phone, so it was shut off, and that her sister had been bringing her to the appointments, but her sister's job shift had changed and she was no longer available to take her to and from the clinic. So she had a transportation issue. I had already looked up the patient's insurance, and door-to-door transportation was covered for her. She simply was not aware of that fact. No one had ever told her. So I explained to her how to call and arrange for a medical ride to and from the appointments. And guess what? She began to make it to her appointments. But it was a resource that she had available that no one had ever explained to her. And again, by going out into the field, I got the backstory on why this young lady wasn't making it to the clinic, and it was transportation issues, which is very common. And as I followed the case, sure enough, she got good care. She delivered a healthy baby, and that was a good outcome. But you're getting that backstory stuff is really critical sometimes to making sure patients get to the care that they need. And so that's right. And so yeah, that's what I wanted to offer around that piece. Thank you.